All right, so today we're going to be going over MR gating in cardiac. I switched it up. Usually I cover vascular, but we're actually going to be using the next two lectures on vascular. It's a little harder concepts to learn than cardiac gating. And cardiac gating kind of goes hand in hand with our artifacts lecture we went over last week, where we were talking about phase mismapping and motion artifacts and gating, along with respiratory compensation, are ways that we can compensate for that particular artifact. Question, how did the artifacts test go? We good? The chart helped out with studying and knowing which axis and how to correct for it. So it's a good document to have. All right. So these are the objectives we're going to be talking about today. We're really just going to be talking about gating and ways to compensate for it. And the gating is really just a method to reduce that motion artifact caused by phase mismapping. Another name for that phase mismapping obviously is motion, but then you have ghosting. So just a quick review from last week. And this is caused by our involuntary motion of the heart and the pulsatile flow of the blood through the atrium, through the ventricles, through the aorta, all those structures. Involuntary motion, you just have to be able to use gating, but voluntary motion, so we are doing the thorax, so we can have them hold their breath during these procedures, but then we use the gating for the heart motion. We're going to be using the electrical signal of the heart, so we're going to be looking at that waveform to trigger each pulse sequence. So usually our pulse sequence starts a little bit after we get that peak of that QRS wave. So right at the peak of that R wave, that's usually when we start our pulse sequence, because a little bit after that, then our heart starts to relax, it calms down, there's going to be less motion during that period. So with this cardiac gating, we're triggering that excitation pulse, and typically we're going to be using a gradient echo pulse sequence because it's fast. So our excitation pulse is going to be variable, so usually we have that alpha flip angle that's less than 90 degrees. And we're going to time that at the same point within the cardiac cycle, and right after that R wave. We have two methods. We could do ECG, or also called EKG. It's where we're going to be using those leads and electrodes that we place on the patient. So remember, we got to take the non-MRI safe leads off from the floor if they are an inpatient, and then replace them with our MRI safe leads. If they're an outpatient, sometimes we have to just prep them. Sometimes you need to shave their chest, just get their hair away from the electrodes. Make sure it's dry, not sweaty when you're placing those electrodes, or else they are more likely to detach. Once you have placed an electrode, don't rip it off and place another one, because usually if you have to take it off, you're going to lose that stickiness and it's not going to be able to stick again to the patient. And then we also have peripheral gating. So this is where we're using that pulse ox that we clip to their finger to detect perfusion within those capillary beds of the finger, and then that's when we time our pulse sequence also. Usually it's delayed a little bit of time because we have now gone from the heart to the periphery, so we wait usually a little bit longer because it takes a little while for the blood flow to get from the heart to those capillary beds. So we'll talk about that. Here are just two images of an ungated cardiac exam versus a gated cardiac exam. So you can see here, the patient was able to hold their breath, so we don't have the motion of the diaphragm, but then we could not compensate for that involuntary motion of the heart beating and the blood flowing throughout that heart. So then we have gating, and we're able to see those chambers of the heart that we need to see during our cardiac imaging. All right. So before we talk about our ECG, let's just quickly go over the blood flow through the heart. So going back to our anatomy class or our cross-sectional anatomy class, so blood is coming from the inferior vena cava and the superior vena cava, and it dumps into what part of the heart?
The right atrium.
Right atrium. And it goes through which valve? Into the right ventricle. Tricuspid. And then once it's left the right ventricle, what valve does it go through? Okay. And then it goes into which artery? Because we're leaving the heart.
Pulmonary.
Now, is the pulmonary artery oxygenated or deoxygenated blood? Deoxygenated. Okay, then we go to the lungs. We get the exchange of CO2 and oxygen. And it comes back to the heart through which vessel?
Pulmonary veins.
Pulmonary veins, oxygenated blood. Dumps into which chamber of the heart?
Left atrium.
Left atrium. Goes through which valve? Bicuspid or mitral valve into the
Left ventricle.
left ventricle. Left ventricle has the largest myocardium, thickest muscle, because it's pumping to basically the rest of the body. We have those papillary muscles that cause the contraction or relaxation of that particular ventricle. And then once it's left, the left ventricle, we go into the what? Aorta. We have basically the root of aorta, which usually that's where it branches off into those coronary arteries that feed the heart. But then we get to the aortic arch, and what are the three vessels on the aortic arch? We don't have the right, because remember it goes up and then it branches off into the two right vessels. But what's that first?
On the left brachiocephalic.
It's not the left. It's just the brachiocephalic first. It's the first one. And then remember the brachiocephalic, right common carotid, right subclavian. Second major vessel we come to. This is a good review. I just went over this with the students in cross-sectional. What's the second major vessel off the aortic arch? Left common carotid. And then the final one is the left subclavian.
Clearly need to read this.
And then you go down, so you got your thoracic aorta, abdominal aorta. So just quick review. We will be going over the different planes and slices of cardiac next semester. This is really just a particular lecture on how to compensate for that basis, which we just went over. All right, so these EKG leads, every vendor has different ones. Most of them have 4, some of them have 3, but usually the black goes over the what? So you don't see the black on here, but where would the black go if you had to choose, if you had 4?
Over the red one?
Over the red. Smoke over fire. That's a good way to remember. And then green is your ground, and then usually white is just over top of green too. So then you have the red and the white at the levels of the heart. Usually people put the white where the right atrium would be, and then the red where the left ventricle would be. Okay? So this measures the voltage difference between those 2 points. The green should be grounded, so that can really be kind of placed anywhere, but usually they have all 4 of them kind of right in this area. And then the electrodes may change a little bit depending on the vendor. And usually they have a diagram on the package that ripped them off to help you out with that. Here is the electrodes here, and then the battery that you need to make sure you're charging throughout this and replace when you start the procedure. And then you have the foam pad because we don't want those electrodes or any of the wiring to touch the patient because we don't want to induce current in the patient and possibly shock them, helping the voltage. So a little different from the ones that they place on them in the ER. So you guys have seen those little stickers that they place across the diaphragm basically. So that gets a little bit better reading than what we get, just because there's a lot more electrodes involved in that, so they get a better, more accurate reading of the waveform. But what we're really dealing with is something that looks like this. So a lot of people just kind of put the green and the red below the nipple line, and then the white and the black above the nipple line. And you want it on the left side of the patient, because that's where obviously the majority of the heart is going to be at. Okay, so our static magnetic field actually interacts with this waveform from the EKG. So this is always a registry question, so make sure you highlight this word here. Magnetic hydrodynamic effect. So this is when a small voltage generated by ionic currents in descending aorta. So what this does, it usually depresses our R wave a little bit, and it elevates our T wave. So here is our T wave normally. We have 0 Tesla, so we haven't put the patient in the actual bore of the magnet. So you can see how our T wave is down here. But then as we go to a 1.5 and a 3 Tesla magnet, as the static magnetic field gets larger, you can see that T wave elevating. And then also our R wave, which starts way up here, actually starts to get depressed. Okay? So why is that troublesome? Which particular letter are we starting usually our excitation pulse from? Which one?
R.
The R wave, because the R wave has that spike. That's when the ventricles are contracting, and it creates this major spike. So if we have 2 peaks here, sometimes it's hard for our system to detect the exact moment when the ventricles are contracting. So that's why it's a little harder sometimes to get a good accurate reading of the waveform on a 3 Tesla compared to lower strength magnets. Yeah, you get better signal, but also remember you're going to heat that patient up more. So sometimes it's not always the best option to do a cardiac exam on a 3 Tesla magnet, especially with all the stents and devices that they might have in there, and magnetic susceptibility artifact, patient heating, and then this elevated T wave and the compression of the R wave. So 1.5 might be your go-to static magnetic field for cardiac exams. And when you guys might notice this also when you have a nurse in your department and they're monitoring the patient, and you have that diffusion scan. Remember that diffusion scan? Very rapid, very loud, and those gradients are switching on and off very rapidly. That causes a little bit of a magnetodynamic effect within the heart also. And sometimes nurses freak out when they haven't been to MRI before, and they see that waveform kind of going arrhythmic. Sometimes they think that something's going on with the patient, but it's really that static magnetic field interacting with that waveform. So you have to remind the patient or the nurse that this particular pulse sequence is very rapid, very loud, and those gradients are switching on and off very quickly, so it could interact with the patient's waveform, make them look like they're having some kind of episode when they're really not. So maybe allow the diffusion scan to finish, and if that heartbeat is still irregular, have the nurse go in and monitor the patient. But just to let you know, the nurses sometimes freak out when they see these effects on their waveform. All right, so what is each wave? So the first wave we interact is our P wave. So this is our atrial systole. So we have systole, diastole. So systole is contraction, diastole is relaxation. So you're going to see the biggest spikes during the contraction. So our atrial systole, it's a contraction, but remember those chambers are a lot smaller than our ventricles. So we do get a little bit of a peak, but it's not nearly as large as our QRS complex, which is our ventricle contraction. So our ventricle contractions create the largest peak. It is the QRS complex, but a lot of people just say the R wave because it's the largest, and the R is right at the top of this wave. And then your T wave, it's actually a little bit larger than your P wave because those ventricles, which are larger chambers, are relaxing. So they're actually creating more of a fluctuation in that wave than a atrial contraction. So this is our T wave, which is where the ventricles are relaxing, filling back up with blood. And remember, we're trying to time our pulse sequence with this wave. So this is just kind of a breakdown of what it normally should look like. P wave, QRS, and then our T wave a little bit later on. So you can see here, we do not want to be imaging during this time right here. All of this time right here, we do not want to be imaging because that's going to create that phase mismapping on our particular image. Because those phase shifts are not going to go into the correct area K space, and then once they go through the fast Fourier transformation, it will look like that streaking across the patient. So remember that aortic coarctation image that I had last time, where the patient was holding their breath, but we could not compensate for that heart movement, and it created that artifact that went across the image. So if we image during this time, that's what would happen. So when we are using the cardiac gating, the RF pulse is initiated by our R wave. So our R wave is used to trigger our pulse sequence. And remember, our pulse sequence is typically going to be a gradient echo pulse sequence. And it's gradient echo because we usually can fill all the lines of K-space in one TR period because we have very short TR, very short TE. Sometimes it would be that single shot frequent session. Sometimes we utilize that half Fourier where we're filling half the lines of K-space and then we replicate that. Sometimes we use a zero fill where we fill half lines K-space and we fill in zeros for the rest of the time. But a very fast pulse sequence because we need to image the heart when it is not moving. What is a normal heart rate? 60 to 100. Okay? And what's it called when you're above 100? What's the term for fast heart? Tachycardia. And what about below 60? Gradient heart rate. Good. So slow heart rate. If you have an athlete that is trained like a marathon, like a guy that ran under two hours for the marathon, what do you think his heart rate is? Is it below or higher than 100?
Below.
Below. Usually those really good athletes have lower, kind of quieter heartbeats, and they're usually around 40 or 50. So we use that R wave because it has that greatest amplitude. So that's why, it's a little troublesome when that T wave is elevated at a 3 Tesla magnet. And we have two types of gating. We have prospective and retrospective. But prospective is when we're using the peak of the R wave to image just during the point when the heart is relaxing. Retrospective gating is we image the entire time through all the different phases of the heart, when it's contracting, when it's relaxing. So you can see here, with retrospective gating, that's more of our cine imaging, where we're imaging it while it's actually functioning. So that's like functional MRI imaging, where we're watching those ventricles contract and relax, where we're watching those tricuspid valves and bicuspid valves open and close, and if the blood is going into the ventricles correctly. Sometimes there's a little hole within the intraventricular septum, and we can notice that with our retrospective gating. So we have two types, prospective and retrospective. But prospective is where we're imaging in short bursts, and we're timing it with the R wave. In retrospective, we're imaging during the entire time, and then we sort out the data afterwards. So here's a good image of prospective gating. So scan time is triggered from the beat to the heart, and we're usually timing it off that R wave. Right here, if I blow this up a little bit, you can see here how we're using that R to R interval to time our pulse sequence so that we're imaging. We usually wait a little bit longer, but we're imaging basically during the entire point when the heart is relaxing, filling up with blood, so that there's no motion here. And then retrospective gating, we're imaging during the entire time. And then here is that retrospective gating. It requires image data during the entire, all the different phases. And then it does some reconstruction. This is usually performed for cine type imaging. Cine, almost like a movie format where you're actually watching the function of the heart or watching the valve in the interrography exam. So they've changed the interrography exam. I was working with George down at Winship. They used to have some cine imaging to image the small valve to evaluate the Crohn's, and you could actually watch the contrast going through the valves. It's pretty cool. You see the Hofstra kind of contracting and relaxing. So they used to have the cine imaging of the valve, but they've changed that. And they don't do any more cine, but they do cine imaging still of the heart, watch it contract and relax, watch the blood flow go throughout the heart. All right, so we need to create a TR. So the TR is based off that R wave, and we're usually starting our pulse sequence there. And depending on if we want a T1 or T2, remember our TR is short for T1, and then our TR is a little bit longer for T2 or proton density. So sometimes we can't really get a TR from just one R to R interval because it happens so quickly. Especially if we have a very fast heart rate, like 70 beats per minute, our TR is going to be only like 700. So that's T1, right? But if we need a T2 or proton density, we need to wait a little bit longer. And we actually time our pulse sequence between our first R interval and then like our second or third R interval. So our TR is controlled off of these R to R intervals. So if you have a tachycardia patient, we have a shorter R to R interval because it's happening quicker. If we have a slow heart rate, we have a longer R to R interval. But that's what our effective TR is. It's a TR set off of our R wave, triggered by our R wave. So I have some questions we'll work on, but finish passing these out. Did you get them, Lily? So we'll work on the questions today, and then this is just, we'll talk about later. This will be our next 2 lectures. It's a little small, sorry about that, but I can always print them up and make it a little larger if we need it. All right, so let's do our first effective TR, trying to predict what the effective TR is going to be based off of our patient's heart rate. So we have a patient that has a heart rate of 60 beats per minute. So we need to now calculate our R to R interval. So we get this 60,000 number from basically we have 60,000 milliseconds within a minute. Because remember, we're doing beats per minute, so we have to convert that from minutes to milliseconds. So we have 60 seconds in a minute, so 60 times 1,000, because 1,000 gets us to milliseconds. So that's where we get this 60,000. Okay? So then we have the 60,000 milliseconds, and we divide it by our beats per minute, and that gives us So let's imagine we do have that athlete that has a heart rate of about 40 beats per minute. What is our effective TR with an athlete that has 40 beats per minute? 1,500 milliseconds. So a TR of 1,500, could that be a T1? Our TR is too high for a T1. Remember, we want our TR to be about 300 to 700 for a T1. So you can see how sometimes you have to wait a couple R intervals, R wave intervals, to get an appropriate T2. All right, and then here's an example. If we have a heart rate of 120, it's just at 60,000 divided by 120. So then our effective TR is 500 milliseconds. So that gives us our T1 imaging. So you can see here how the effective TR based off of our beats per minute is sometimes restrictive of the type of weighting that we need to utilize. So if you do desire a T2 or proton density, sometimes you have to use every second or third R interval to get that longer TR. And if you have beats, like we had that 40 beats per minute for that athlete and we got 1,500, sometimes you have to cut off that TR before we even get to that next R wave, just to get your desired weighting. But remember, we're still imaging within that relaxation period of the heart, where there's less motion. So if we have that patient that has 60 beats per minute, you can see at first R to R interval is at 100 or 1,000 milliseconds, and then 2,000, 3,000. So if we do desire that T2 weighting, we need to wait to that third interval. And if we desire a T1 weighting, we have to cut it short, because 1,000 is still too long for a T1 weighting, because remember, 700 gives you the limit. So slice acquisition, this is to basically get the best images where you have no motion and you get the same heart tissue on every slice. Ideally would be to align your slices with the same phase of the heart. So remember, we do not want to image during this QRS complex, but then we start our pulse sequence and then we acquire our slices after that. But ideally, we would want to do that consecutively for each TR period, effective TR period, at the same point. So here, we are not aligned with the same phase of the cardiac cycle. So ideally, you would want to be able to shift this over so that you're imaging and acquiring slices during the same phase of cardiac cycle. So, but this is still acceptable because we're still not imaging during that massive contraction of the ventricles. So this is more of what usually happens. It's just going to be slightly off, but it's still acceptable because you don't get that massive phase mismapping from that cardiac contraction. All right. So our system has built in these safeguards so that we are imaging further away from this QRS complex. And those safeguards are trigger window right here and our trigger delay. So you can see here we wait to image with our trigger delay, and then we use a percentage for our trigger window to stop before that QRS complex. And these are safeguards so that we get better cardiac gating. And then you basically take whatever your effective PR that you calculated, 60,000 divided by whatever the beats per minute, and then subtract these two things, the trigger window and trigger delay, to get your available imaging time. So these are some of the problems we'll solve today. But these are just safeguards so that we're not imaging during this contraction of the ventricles that cause the greatest amount of motion. All right, so our trigger window, which is a percentage of the R to R interval, and typically you want it about 10 to 20%. And this is to compensate for patients that have arrhythmias, just things that are unpredictable within their cardiac cycle. So arrhythmia is just being irregular heartbeats. So as you hook up those electrodes, you'll see, like this patient, ideally you would want it 60 beats per minute, so you would want a peak R wave almost every second. But that doesn't happen. Usually, boom, we get one, and then maybe it occurs at the next second. But then, for some reason, it waited 2 seconds, and then 0.5 seconds. So most patients, remember, we're doing these cardiac exams because they have an issue with their hearts. So we need to be able to compensate for that QRS complex not being exactly where we think it is each time. So it's to compensate for these arrhythmias. So with this trigger window, we usually give ourselves about 10 to 20%, depending on the patient. If they have, a more irregular heartbeat, you want it 20%. But if you have a patient that, is pretty consistent, but then every once in a while, and you'll just monitor it for a little while just to see how it how the rhythm is. But if it's not as irregular, just 10% will be fine. So you take that effective TR, so this is for 60 beats per minute, remember it's 1,000 milliseconds, and then you times it by 0.1, which is 10%. So the system stops scanning at 900 milliseconds before that next R wave happens. So remember, our trigger window comes before that next R wave. So if this R wave right here was 1,000, so if our effective TR was 1,000, TR is 1,000. Then our trigger window, which is 10%. Here's 10% again. So we basically just multiply 1,000, which is our available imaging time, by 10%, and we get 100. And then you basically subtract that 100 from the 1,000, and then that gives you 900 milliseconds of available imaging time. But that is just for one of the safeguards. But remember, we have another one, the trigger delay. So we still have to factor that one in. So this is that trigger window. As these arrhythmias increase, and we maybe increase our trigger window up to even 25%. This is what's happening, is we have this trigger window, which is a percentage, and it's 25%. This is what we predicted. It should occur like right around here, but sometimes the QRS complex happens before or it happens after. And what the system does, it rejects those QRS complexes and that affected TR for that particular filling of K-space, so we don't get the phase mismapping. It rejects that, and so we don't get that phase mismapping. So we don't get the phase mismapping, but you can see here, if we keep getting these irregular heartbeats, it takes a lot longer for us to scan, because our system's constantly rejecting a lot of these QRS complexes, and yeah, we're not getting the motion, but we're also not getting the pulse sequences and the K-spaces filled. So remember, we need to fill all K-space, all those rows of K-space to get our image, but if our system keeps rejecting each line of K-space because it's occurring at the wrong time, it's going to take longer for us to scan. So that's why sometimes these cardiac exams, depending on the patient, can last up, hour, 2 hours, even 3 hours sometimes. The most experience you'll get with cardiac will be at Miss Deborah is the MR tech, and they do cardiac exams in the morning at the tower. And so as you guys rotate through there, it's a new clinical site, and I'm actually going to use it at the end of this semester. You guys will get a little experience with that cardiac imaging. So, and it's a great experience to get because not a lot of techs, once you go out into the field, have experience with cardiac, so it'll make you more desirable on your resume. So if you rotate through there, make sure to put it on your resume as you get closer to graduation that you have done some cardiac imaging. All right, so what's the second safeguard? Our trigger delay. So this is the time that passes after the system detects that peak of the R wave and then begins scanning. So we have that window which happens at the end of that effective TR. Now we have a trigger delay to compensate at the beginning. Typically this is just displayed in milliseconds, and it's a few milliseconds, like 40, 50 milliseconds, that we wait just so that we're imaging during diastole, during that relaxation. So we wait just a little bit for that QRX complex to really spike, and then we wait a little bit longer for complete relaxation of the heart. So you can see here, trigger delay is at the beginning, right after the QRS complex, and then the trigger window is a percentage, and it occurs at the end of your effective PR. So let's just label these. This R to R is our effective PR. Trigger delay is usually expressed in just milliseconds. And typically it's around like 40 to 50. And then our trigger window is a percentage. So whatever our effective TR times that percentage and that will be your trigger window. And then your acquisition window, this is when we're imaging during because you can see here that this is the most desired time because there is no motion of the heart. Everybody got that written down? All right, so now we need to calculate our available imaging time, and we have some problems to work through. So to calculate our available imaging time in an MR cardiac gated sequence, this is the formula. The imaging time, or the available imaging time, equals the R to R interval, which is our effective PR, minus, in parentheses, the trigger window plus the trigger delay. Those safeguards. Trigger window and trigger delay are safeguards. So if we have, this is an example, if we have a heart rate that's 80 beats per minute, our trigger delay is 50, and our trigger window is 10%, what is the available imaging time? So first we need to find out our effective TR. So our first thing we need to do is take 80 and take 60,000, which is our milliseconds per minute, and divide it by 80, which is our beats per minute. And that gives us our effective PR. So this number right here, 750, is our effective PR. Okay? That is also our R to R interval. So now we take our 750 and we subtract our two safeguards. Our first safeguard is our trigger delay, so we just basically minus the 50. But remember, it's within our parentheses, so we just add it to our trigger window. So 50 plus 10% of 750, which equals what? 75. So 75 plus 50 equals 125. So you subtract that 125 from the 750, and our available imaging time, our final answer is 625. Okay? So 10% of 750 is 75, plus the trigger delay of 50 equals 125. And remember, that's in parentheses, so it's 750 minus 125, and your available imaging time is 625 milliseconds, which is a good TR for a T1 weighted imaging. We'll have a couple of those so that you guys can practice. All right, and then we also have our peripheral gating. Our peripheral gating works the same as our EKG. It's just not as sensitive, and it really doesn't work as well. What's happening is we get that photosensor that attaches to the patient's finger, and it's detecting perfusion of blood in those capillary beds. So as blood gets pumped from the heart into the capillary beds, it basically spikes, just like with our QRS complex. We get the most perfusion at a particular point, and that's when we want to stop imaging, is when during that really high perfusion time within the capillary beds, because that's when our heart is contracting, allowing blood to go out to the system of the patient. So So this detects increased blood volume in the capillary beds. This is also sometimes referred to as perfusion. So it's different from perfusion imaging, which we'll go over in functional MRI, but just the word perfusion basically means that blood flow to the tissue. And perfusion imaging, like when we do those in the brain, you guys have done perfusion scans of the brain, right?
Mm-hmm.
Where we're injecting contrast at a very high rate, right? They usually say increase your cc's per second to what? I know your CIs have you change your on your power injector, because this is anytime you do a perfusion, you have to use the power injector. You can't inject quick enough. 3 to 4, just cc's per second. So normally, like it just hand injects like 1 to 2 cc's per second. But a perfusion scan, we're injecting a lot faster, 3 to 4, even 5 sometimes cc's per second. Okay.
So you say blood volume is perfusion?
Yeah, blood volume to tissue. So how is that blood volume getting to the tissue? Because if you have a decrease in blood volume going to a particular tissue, that could be indicative of a certain pathology, like in the brain. Like if you're not getting blood flow to a certain part of the brain that normally does, they could say, oh, there's like a restriction within the vessel, or there's a tumor, or there's other things. So you get that perfusion imaging, and then you get that beautiful color mapping that goes along with it. So you get the perfusion imaging, and then the radiologist looks at this color mapping of how well the different tissues in the brain get blood and how fast they get the blood. So like if you have some kind of restriction, it might not be red, it might be like a blue color. So those colors indicate different things. So we'll go over that with our functional MRI. But all you need to know now is the term perfusion just means increased blood volume within the tissue. So then that photosensor detects that increase in perfusion within the capillary beds and starts the pulse sequence. And you still have your safeguards, your trigger window, and your trigger delay. So this is what our pulse ox looks like. Remember, you have to have an MRI safe pulse ox, because the pulse oxes from the floor are not MRI safe and could possibly burn the patient. Remember that image I showed you from MRI safety where they had a pulse ox on a child's toe and it burned the child's toe? Same thing. You make sure you're using an MRI safe pulse ox. And that R wave, usually there's a delay of 250 because remember, it takes a little bit longer for the blood flow to get from the heart to the capillary bed. So there's a trigger delay typically of 250 milliseconds. So we do have the safety aspects. Remember, we're switching them over to MR safe, but remember to not loop. We don't want to create a closed loop, which could induce a voltage due to the Faraday's law. Make sure that these wires are not in contact with the patient's skin. Don't let them touch the bore of the magnet. Make sure there's no equipment or fraying of these wires that could possibly burn the patient. These gating applications are used in the chest, great vessels, abdomen, spinal cord, brain. So when we're doing the brain and the spinal cord, what do you think we're gating? CSF. Yep. Abdomen, respiratory, and blood flow, chest, the heart. Really. Peripheral gating, we attach the pulse ox to the finger for brain, CSF flow type things, vessels away from the heart, so smaller vessels, not the aorta, more periphery vessels. And the EKG gating is great for the heart and chest. So if all this fails, if your system is just completely gone haywire for that particular day, you can do pseudo gating, which is basically you finding out what the patient's heart rate is, factoring in a trigger delay and trigger window, and creating an available imaging time. So that's why we do these equations, is if your system fails and you need to find out an effective TR where we need to have an adequate imaging, available imaging time, this is what pseudo gating is where we're basically predicting what the TR will be and the available imaging time. And going back to our retrospective gating, the cine imaging, this is where we're talking about how we're acquiring throughout the entire, all the phases of the heart filling with blood, you know, contracting, blood getting sent to the rest of the body. We're imaging during the entire time. And that is because we're interested in the cardiac function and the wall motion and how those valves open and close. Sometimes those valves open, but then one of the lids do not actually close all the way. And we get a little bit of backflow of blood. So this is, once again, a gradient echo pulse sequence, T2 star coherent. So our single shot free perception or our true fist. And in gradient echo pulse sequences, remember our blood is going to be bright because we have the gradients along the length of the magnet, so we can rephase those spins. Yeah. Keep coughing just like I think we're just going back and forth. But the cine imaging is acquired through this retrospective gating. So let me show you an image of what cardiac cine imaging looks like. These are the different views. Oh, here. So here is a two-chamber view. It's very fast, but you can see all the different phases of a one basically beat of the heart. So here we actually have the left ventricle. Here are those papillary muscles right here that allow that really good contraction and relaxation. You know this is the left ventricle because this has the largest myocardium. This is a gradient echo pulse sequence because blood is bright in a gradient echo, so it's that T2 star coherent. Here is the diaphragm up here. So just kind of give you reference of where we're at. And we'll go over this next semester when we start to go over the slices of the heart. And then this is the right ventricle here. So another large chamber, but not as large as the left ventricle in terms of, you know, how large the myocardium is. So you can see really quickly the heart contracting and relaxing. So cine imaging is that on a continuous loop. So if I just basically had that loop button, we could watch this over and over and watching the heart contract and relax. So they like to see how all those muscles, because there could be an area of this myocardium due to a myocardial infarct, MI, that is not actually moving compared to the rest of the wall. So that could be damage to the wall of the heart, which is caused by blood flow not getting to that particular area of the heart, myocardial infarct, just a heart attack. Because remember, our heart blood flow is supplied by those coronary arteries. So those, right off that aortic root of that arch, all the vessels of the heart get supplied with blood first. So like before that goes to the aortic arch and the rest of the body. So if our left anterior descending coronary artery is clogged in some way, that can lead to a heart attack. So they usually call that the widowmaker. I don't know if you guys have heard that before. The left anterior descending coronary artery is called the widowmaker because it's killed a lot of male patients from heart attacks. Maybe that's the one that almost got Bernie Sanders. But he's had a stent.
Yeah.
He says he's all right.
He did well last
He,
night.
he looked healthy.
Yeah.
He's those stents. My grandmother has stent, and she, I think that thing was placed 15 years ago. So I mean, stents, if they're placed and they catch it in time, the patient can live for a long time with those stents.
Yeah, my grandfather has 3.
Oh my god. Makes sense.
Yeah.
Wow.
Let's just say he should have been on a diet long time ago. He's doing well now.
All right. So we have covered pretty much all cardiac gating. Remember, cardiac gating is a compensation for which type of artifact?
Motion.
Motion. Also, are the 2 other names for it? And ghosting. Yeah. Phase mapping and ghosting. So we have 2 types. We have peripheral and EKG. And what this is doing is basically calculating our effective TR, subtracting our safeguards, our trigger window and trigger delay. Our trigger window is a percentage, and our trigger delay is usually just in milliseconds. And then anytime we do this gating, we always have to be concerned with the patient's safety because we have all these extra electrodes and wires. Remember, gating we could do prospectively and retrospectively. Prospectively, it might take longer because remember, we're only imaging when the heart is relaxing. Retrospective gating, we're watching all the different phases of the heart. That's cine imaging. And then if all else fails, we get our pseudo gating, which where we calculate the available imaging time from that equation that I gave you. All right. So let's take a quick break, and then we'll come back and work on those 6 problems. We'll go over the answers, and then we get out of here. Any questions? So for the online students, the students have been working on this worksheet for the last 5 to 10 minutes on effective TR and available imaging time. So we're just going to go over these 6 questions here. All right, number 1, the effective TR patient heart rate of 70 beats per minute. So 70 beats per minute, what type of heart rate do we have? Normal. So normal here. All right, and then how do we get our effective TR?
60,000 divided by 70.
60,000 divided by 70, which equals what?
57.
Milliseconds. All right, and that 60,000, once again, for the online students, comes from there's 60,000 milliseconds within a minute, because our minutes cancel out beats per minute and minutes. So to get to 60,000 at 60 seconds within a minute times 1,000 milliseconds within a second. All right, next one. H heart rate of 40 beats per minute. That gives us what type of heart rate? Right. And then our equation 60,000 again divided by 40. And that equals what?
1,509.
1,500. So you can see here, both of these are outside of our range of our T1. And a little bit too low for a T2 weighted, so you have to wait some intervals. Number 3, heart rate of 120 gives us a tachycardia. And then our 60,000 divided by 120 equals what? 500. right, so our next three, we had to find our effective TR, but then we have to subtract out our safeguards, our trigger delay and our trigger window. All right, so let's first find our effective TR. So 60,000 divided by 60 equals 1,000 milliseconds. So now we have to take our 1,000 and subtract our trigger delay plus our trigger window. All right, so our 1,000 minus, what's our trigger delay?
60 ms.
60 plus, and what's our trigger window?
200
200, because 20% of 1,000 is 200. Everybody see that, right? So then that equals what? What's 1,000 minus 260?
740.
740 milliseconds. So that's our final answer. Okay. So then let's do that again down here. So our heart rate is 80 beats per minute. So first find the effective TR. That equals what? 750. So then our 750 minus, what's our trigger delay? 40 plus, what's 15% of 750?
12.5.
112.5. So then what's our final answer?
597.
597.5, right? Okay. Our final answer, available imaging time. All right, and then our last one. 1,000 divided by 90. That equals what? 6.6. Okay, so then we take 7 minus our 50 plus, and then 10% of 6 equals what?
56.6.
6.67. So our final answer is what?
550.
All right. So you will definitely see both types of equations on the registry and on my quiz, which will be 2 Sundays from now, and on the exam for this week. So just make sure you know how to do these questions. Any questions?
What was the answer for What was the answer for number 5?
Number 5 is 597.5.